me saying you can contact her directly. Right, shall we move on to the next item? So we've got Paula talking to us about our COVID vaccination programme. So Paula, over to you.
Thank you very much, and that's a very hard act to follow, Tammy. I shall do my best. Okay, hi everybody. So just to give a very brief update on where we are with regards to the COVID-19 vaccination programme. The first slide just summarises the last set of data that we had, which was as at the 21st of September, which is, you can see, as a borough as a whole, we are currently at 62% for first doses of vaccination given. And for seconds, we are now at 55.1%. You may remember when I did a presentation previously, around July time, we were at around 20%, just under 20% for second doses. So we have seen a significant improvement in uptake of our seconds, both at the sites that NHC is supporting at SLG in East Ham, but also at Essex Lodge, and with the support from Wood Grange as well, but also through Helen's roving model and the support from the LBN team with their community pop-ups also. So significant progress has been made. We do still have some way to go, and the offer for first and seconds does continue, even though we have now started the boosters. If we could move on, Maggie, please. Can I get the next slide, Maggie?
It's there. Vaccine produce names. Can everybody see it?
No, we're still on the table.
Oh.
Thank you. So just a couple of really key updates. One is that you may have seen in the press that the vaccines have largely all now been given brand names. They've all received approval. So on the packaging, you will see that there are some changes. So Pfizer is now called Comirnaty. The Moderna vaccine, which is generally used in the mass sites or the pharmacies, is now called Spikevax, and AstraZeneca has now been called Vaxzevria. And the brand names are being used across the world now, so there is commonality in all of the countries that are using these various vaccines. So the supply names currently on platforms such as Pinnacle will still be Pfizer, Moderna and AstraZeneca at the moment. There is work underway to change those. So over time, patients will also see those names being changed on the NHS app if they're looking to secure a COVID pass. What won't change is that all of the product information leaflets, etc., which patients have now become used to, will remain with Pfizer, Moderna and AstraZeneca. So some places the names will change, others you will see both names joined together with one in brackets. In other scenarios, then it'll be either, for instance, Pfizer or Comirnaty. We've also provided this information out to our LBN colleagues as well, because they do get a number of calls where patients are now confused as to which vaccine they have actually had. Next slide, please, Maggie. Thank you. So as you all know, we are now into phase 3 of the programme, which is our boosters. Each PCN designated a site from which their booster programme will be delivered on behalf of their patients. And I've just put up here a list of the designated sites and the PCNs that are attached to those. Boosters can only start to be given once a patient is at least 182 days post second dose. They did start off by saying 6 months, but generally there seemed to be agreement that different organisations were calculating 6 months in different ways. So they've now given us days rather than months. Pfizer is the preferred vaccine for all patients, regardless of what dose, whether it was Pfizer or AZ that they had for their first and second. The only time that they would be offered an alternative would be if they are contraindicated to take Pfizer. If a patient has had Moderna for their first and second, they will be offered a half dose of Moderna for their booster. But as I mentioned, generally Moderna is only in the mass sites or the pharmacies. So the boosters currently are recommended for those living in residential care homes for older patients, all adults over the age of 50, frontline health and social care workers, those who are 16 to 49, but with underlying health conditions that put them at a much higher risk of severe COVID, as well as adult carers and adult household contacts of immunosuppressed individuals. Next slide, please, Maggie. Thank you. Alongside the boosters, we continue to provide what is now called the Evergreen Offer. So this is first or second doses to patients that haven't yet taken up that offer. Again, they will be now offered at the designated site that the PCNs have nominated. So SLG, as an example, will no longer provide a borough-wide service. Second doses remain, time frame remains the same. So they shouldn't be given earlier than 8 weeks after the first, unless there is a medical reason to do so, which should be supported by a letter from a GP or a clinician. Examples of where that may be necessary are patients that are due to start chemotherapy, and the timing of the second dose needs to work in terms of the cycle of chemotherapy that they're going through. I've also put on here, sorry, just back slightly, Maggie. I just want to cover the other way, sorry. Perfect, thank you. The other thing just to stress, and you will have heard about this a lot now, is that within the phase 3 programme, we are now giving what's called a third primary dose. This shouldn't be confused with the booster. So the third primary dose is offered 8 weeks post second dose to any patient who's 12 years and over who is severely immunosuppressed. So letters went out to practices on the 1st and the 15th of September, setting out the detail of how to run the searches for the patients that need a third primary dose. And when you get the slide pack sent round to you, I've also attached on here a link to the JCVI guidance on the third primary dose. There have been some concerns raised about the searches that are available, that they're picking up some patients that may not be eligible in line with JCVI guidance. So the recommendation from those GPs that have already started running these searches is that unfortunately you do also need to just do a manual check through the patients that are generated just to make sure they are actually eligible. Okay, next slide please, Maggie. Okay, are we able to move on, Maggie?
I can see it. Sorry, I think my internet connection is really slow.
We've got a time lag, I think. So just in terms of the 12 to 15-year-olds, they have been broken down into 2 groups. The first is those that are clinically extremely vulnerable. And I've listed here the clinical risk groups that meet the criteria of clinically extremely vulnerable. For the detail within each of those groups, I would recommend that you do look at chapter 14A of the Green Book. That does break it down into significantly more detail that I wouldn't have been able to fit on this slide. But that's a really good source of information for the patients that you should be searching for to call them in. So PCN sites are able to vaccinate 12 to 15-year-olds who are clinically extremely vulnerable, providing they have completed the 12 to 15-year-old checklist that the meds optimization team sent round when the designated sites were first set up. I believe at the moment there's only one site that hasn't completed, has said that they don't wish to do children currently in this particular group, so they are able to go to sites such as Westfield. But the majority of sites have opted in to do the 12 to 15-year-old clinically vulnerable. If we could move on, please, Maggie. Thank you. The other category of 12 to 15-year-olds are the healthy children who generally will be vaccinated at schools. The programme commenced in Newham this week. So the first school was visited earlier this week. It's being coordinated by Vaccination UK and delivery is via ELFT. And consent is being done by e-consent. So parents are emailed a link to consent online in advance of their child being vaccinated. So all schools have had to have agreed a date for delivery at their school by today. So there is still work underway for those schools that haven't yet got a confirmed date to be scheduled in, but that will all be done by close of play today. There are also plans underway for some PCN local sites to vaccinate those children who are unable to be vaccinated at school, which includes, for instance, those that are homeschooled. We're still waiting for confirmation on which sites that will be. It will not be every PCN site, partly because the numbers of children won't be significantly high, partly because not all sites have agreed to vaccinate children, but also because of concerns around the potential security risks with regards to anti-vax activity. Just for those sites that are going to deliver this service who agree to do so with commissioners, just to note that your current ODS codes on Pinnacle will not work. Any vaccination of 12 to 15-year-old healthy children needs to be done under a separate ODS code, which will be issued to the site, and you will also receive separate stock with a dedicated batch number attached to it for these children. So whilst it will be the same vaccine, Pfizer, it will be separate stock to anything that you might see for your boosters or your Evergreen offer. If we could just move on, Maggie, please. I think it's the last slide. Just to highlight that LBN are currently running a number of Q&A sessions for parents and young adults for any queries, questions, etc. they might have in relation to the vaccination programme. The first one took place yesterday, and then the second one is on the 20th of October, followed by another on the 3rd of November. Wax, who I'm not sure if he's come back on the call or not, having just received his very exciting first delivery of vaccines. Ah, there we are. Wax, you were involved with the session last night, weren't you?
Yeah, we had about 30 joining, went really well, and we're holding more of those sessions. The questions were more about sort of the orientation and stuff like that. And of course about the sort of long-term side effects, and so we covered those off, and hopefully we'll get plenty of positive outcomes from that discussion. Myself, Winston from UEL, the virologist, and the consultant Vanessa Appiah from Barts looked after that session, and actually I'm doing a session next week for North East London as well on the same kind of topic, and we'll feed that back. Yeah, so what I did think is, if I'm sitting on this side, on that in the GP hot seat and in the clinician hot seat trying to explain some of this, you can see the 12 to 15-year-old is complex. I really would recommend everybody goes over the slides that Paul has kindly put together, because they are like gold. And honestly, it will save you so much time with your patients as well. So thank you, Paula, for putting that all together. Thank you.
So Paula, those slides that we can share those slides so that everybody has access to them. Does anybody have any other questions for Paula? No? Okay, good.
No, I think, sorry.
Oh, sorry.
I think Dr. Patel's got his hand up.
Yeah.
Chair, it was the question about the immunosuppression patient. Immunosuppression patient, they also include the thrombocytopenia or something, you know, the genetic disease.
Oh, I think what you're referring to, it's including thalassemia patients. So
yeah.
People that have got, so I think that's why it's important that we don't just batch send out invitations or text messages. Sorry for those of you that have already done that. I think that's why Paula was highlighting, we need to look at those lists, and a clinician would need to review them before you're inviting those patients. Because I think the difficulty that if you're batch sending things out, the difficulty you will have is then taking back that invitation, essentially. I think it's important you run those searches, but review the lists before we send out any invitations.
And the CEG are doing some more work on refining the searches.
Okay, good. Thanks. Wax quickly, then we can move on to the next item.
Yeah, so yeah, Paula's right. They're looking at those searches. Unfortunately, we've got 48 on our list, and so we're having to do it one by one, just to make sure, because there are some things captured on there that shouldn't be. And then also keep an eye out for consultant letters coming back from the hospital as well, for people who aren't coded on our list as well. So there's that little grey area. So we're doing a little bit of work with on reconciling those two sort of groups of cohorts, and making sure, and that might involve a little bit more work from practices, but we'll keep you posted around that. In terms of the healthy that schools, that's fine, but yeah, just keep an eye out, like Paula said, on your immunosuppressed, etc., news kind of situation there, because there are some people creeping into those lists that shouldn't be vaccinated. And as Nazma said in the meeting earlier on this week, you know, we don't need to over vaccinate as well.
Brilliant. Thanks, Paula. If
You're welcome.
anybody's got any other questions or queries, please feel free to contact Paula or any other member of the NHC team. If we can move on to Sergeant Howard, who's here to talk to us about protecting ourselves and our staff.
Good afternoon, everyone. Yeah, my name's James Howarth. I'm a police sergeant on North East Command. So my job is as a partnership sergeant. So I work closely with the local authorities and other key partners. So happy to be here. I've got a very sort of brief outlook on what you want me to cover off. So I'll go over the key themes, and then if there's any questions and answers or particular issues and concerns, then I'm happy to take questions. So when it comes to personal safety, obviously your staff, it's paramount. We won't tolerate violence, threats, abuse, any form of issues around your staff in your practices. So we want to go down the route of sort of 3 key themes of education, engagement, and enforcement. So the education piece sits pretty much with you guys in the practices. So we'd ask that you have a clear policy around abuse and violence and threats, and that all the staff and the patients are aware of it. Advertise that policy, so by all means put the posters up, send out timely reminders to remind people of what's acceptable and what's not acceptable, and sort of try and help change people's mindsets around what they can and can't do when they're in the practices with you guys. Staff training is very key. Run through some sort of what if scenarios, and you know your staff better than anyone. How will they deal with particular situations if they've been confronted with someone? There is conflict management training that you can organise. You can do it online, you can do it face to face. But the key one is that the staff need to realise that every action has a reaction, and that how they deal with individuals could affect the outcome overall. So that then leads on to the engagement piece. So if an incident does occur, then our ask is that you try and engage, you try and de-escalate it as best you can. But obviously in certain situations, there are some people that just won't listen, and it will go to the point of where you need to go down the enforcement route. So if it looks like you're heading in that direction, then by all means try and move the individuals to a side room so it doesn't make a big scene, and also may try and de-escalate the situation. But ultimately, your staff need to be reminded that they can call the police. It's not a problem to call the police. 999 if it's an immediate threat, either to them or to others around them. If someone they're committing an offence, if they're damaging something, if they're threatening someone, if they're being physically violent, then they're all 999 calls, and there will be no criticism for anyone being phoning through to 999 in any shape or form. If it comes to a sort of slow time incident where someone's been there, they've done something, and then they've left and walked off, then that becomes slow time, but that still needs to be reported to us because we need to know about it, and we will deal with it if we can deal with it. So you can report that through the Met website online or through 101. I won't lie, 101 you could be waiting significant amounts of time trying to get through to someone. So online's probably the best way. If that then comes through to us, it will go on as a crime report, and that will be picked up, and it will 9 times out of 10 it will go through to your Safer Neighbourhood team, who I would hope are all engaging with you anyway and providing some sort of reassurance patrols and engagement patrols regularly. If you haven't heard from USNT, by all means, please get in contact with me and I'll nudge them in the right direction. Or if you want to contact your SNT for any other issue, then you can find their details from the Met website. And if you're struggling with the Met website, because again, it's not the most user friendly, the simplest way is to just Google MPS SNT, so Metropolitan Police Service Safer Neighbourhood Team. It'll take you to the Met website with the correct page. You put your postcode in and it brings up your local Safer Neighbourhood Team. It will give you a contact telephone number. It will tell you the names of the officer on there, and it'll even take you to an online form that you can submit, which will go straight through to your Safer Neighbourhood Team. Ultimately, if it's a criminal offence, we will deal with it, and hopefully we'll take it through the justice system. Obviously, it depends a lot on what you guys would like us to do. So if we do take it down as the justice system, then we would expect statements and evidence to progress it through the court system. If you don't want to take it to that point, then again, it's not a problem. So again, please report the incident so we've got an intel picture of what's happening, certainly across the GP surgeries and in certain areas. But if you at a later point decide you don't want to take it to court, then that's fine. We can close the crime report and say that on your say so you no longer wish to progress it. And then obviously you've got your own sanctions that you can take internally, whether you wish to struck people off your lists and all the rest of it. So that is very much a snapshot of sort of the 3 key themes: the education, engagement, enforcement piece. My sort of key takeaways from you would be, please look at your policy and your training, spend time with your staff, make sure they're aware of what the expectations are around them and how to deal with people. Invest in some good conflict management training if you think it's needed for certain members of staff. If it comes to a point where something's happening within your surgeries, then look at the engagement and the de-escalation process. But don't be afraid to call the police if you feel you need to, because at the end of the day, we'll support you. It won't be tolerated, and we'll help out where we can. That is all I have.
Brilliant. Thank you so much. Really, we all really appreciate you taking time out of your busy day to share that with us, share that information with us. So I think with regards to what I think all practices can take away from that is that there's a few sort of quick things that we can do and check that we have in place so that we're all on the same line. So firstly, making sure that there's posters up talking about violence against NHS staff. All practices should have a template letter in place. It might be worth doing something across the borough so that all practices are using the same type of letter, just a warning letter about violent patients. All practices should have a protocol in place. Staff should be aware of what they should and shouldn't be doing in situations like this. In particular, they should be aware of the neighbourhood safety teams. And Sergeant has explained to us how we can get the details for that. I don't know if anybody's got anything that we want to add or any comments. So, Manuel?
Yeah, quick suggestions for those who have the CCTV is a big poster saying that you're on camera, and also what I found as a deterrent, it's not 100%, is to actually have the display screen of a camera right behind the reception screen, so the person can, and the staff keep turning around to point out to that person who's being aggressive that you are on camera and you can see yourself there. And that actually deters that person. So for those practices who have CCTV, just a suggestion. So, and also the other thing is, especially for clinicians who are working behind closed doors, I think you also have to think about whether you can reach to your mouse to actually alert the EMIS alert button. So, I mean, some of the practices, the older ones, they used to have a button underneath the table, which you can quickly knock it with your knee or something like that. But with the EMIS alert, I think there is a slight risk. So we may have to review that alert system. So just to add some pointers.
Thank you. Those are actually really useful indicators. I remember we had an elderly patient that was 90 years old, and I remember when I first met her, the first thing she said, you're sitting in the wrong place. And I had no idea what she was referring to, but it was because she said to me, you should be next to the door. Still remember that. So obviously after that, we rearranged the room. Wax?
Sorry, I might have missed it, but Officer, did you talk about increased patrols, especially in hotspot areas? And how is there a commitment to that as well? Because, you know, it has been pretty extreme, and there's been some extreme incidents that I know that have been reported.
Yeah, so if stuff comes through to us reported, it goes into our intelligence cycle and it's assessed, and then hotspot locations are determined, and then we will increase our patrols and our response. So that's again why it's key that people report stuff. So even if someone does walk off, we still need to know about it, because it feeds into that intel cycle, and then we can deal with it and put the appropriate resources into it. To come on to the point that the other gentleman made around CCTV, yep, brilliant idea. Again, a key one from us is, please, if you've got CCTV, make sure there's someone on site that knows how to use it. So that if we do end up turning up to an incident, we can get that fast time image, we can circulate it, and we can use it, because that's the evidence we need to take to court as well. A lot of court cases get snarled down by the lack of the CCTV being available. And the alert buttons, again, if you've got alert buttons within your panic alarm, within your surgeries, the other option is you can get personal ones that you just carry on you all the time. So you don't have to be location based. It's just you push it and it will go off wherever you are.
I was just going to say one other thing. I know you're extremely busy, and I'm quite sure that you've probably had approaches from various routes. I'm just thinking, Karen, how we can streamline this for our colleagues, because I'm pretty sure John will be making some kind of approach from the borough partnership, if not as that has already happened, or practices as well. So I'm just wondering, is there a way that we could streamline it for our colleagues, so as to free them up to do more of that kind of important work that we've just discussed?
I'm happy to take that away, Wax, and see what I can do. I can talk to colleagues.
Thanks.
Thanks, Paula.
Yeah, just to say briefly that there is also separate security guidance in relation to any sites that are delivering COVID vaccinations following a number of incidents with anti-vax protests. They generally come to site leads, but I'm happy to start sending it around more widely. Maybe we can attach it to the weekly email that Karen sends out, because it is incredibly useful information, and it does give a guide in terms of any recent events and the approaches that have been taken to manage those, as well as some of the ways to disrupt service that has been used by protesters, such as putting up anti-vax posters that unfortunately have had razor blades attached to the back of them, which have caused some injury to staff that have taken those posters down without realising. So I'm happy, if everyone's happy, we can start sharing those much more widely, just to support what you're already doing. And I did just put a comment in the chat. I've only ever had to call police support once to a vaccination site, but the support they gave was superb, and the staff was so extremely grateful.
Thanks, Paula. Right, Sergeant, thank you for your time again today.
No, thank you. I'll hang on if there's any other questions at the end. It's fine. Thank you.
Okay, great. Thank you. So if we can move on to hearing about our vitamin D project. So can I ask Claire, our Assistant Director of Public Health?
Hi everybody, thanks so much for having me here. I'm one of the consultants in public health in Newham's public health team, and I'm here to very briefly, because I realise time's tight, talk about the vitamin D project, and I think particularly focus on how we would love you to get involved if you'd like to. So if we just go on to the first slide, please. I'm just going to, I think, very briefly talk about what is the pilot that we're doing, why are we doing it, how we're planning to do it, and then focus on how we'd really like you to get involved, and any particular questions or things you'd like to raise now or afterwards, and what the next steps are. So if we just go to the next slide. We're doing a 6-month pilot starting in November to basically give out free vitamin D supplements to residents aged 65 and over. We'll combine giving out the supplements with some information about what vitamin D is and why it might benefit individuals and why we're doing the project. And obviously what we're aiming to do as well is use this opportunity to promote other winter health messages, so COVID boosters, flu vaccine, that kind of thing at the same time. The council is funding it and leading on the delivery, but we've designed it with partners from CCG and the voluntary sector and other sorts of settings which will be working with us to deliver the pilot. So I'll talk a bit about that in a moment. If we just go on to the next slide. The reason we're doing this, I'm not going to tell you why vitamin D is important or why we'd want to prevent deficiency, but the issue was raised by the council's Black, Asian, Minority Ethnic Disproportionality programme, which was started in COVID to focus on the disproportionate impacts of COVID and the health issues in Newham and how we can address those. And vitamin D deficiency was raised as a priority. So we know that there's not particularly good evidence about vitamin D's role in COVID, so we're absolutely not going to be sort of selling it as a way to prevent COVID, but it was raised as something that we should be thinking about as a borough. And NICE recommend that all adults take supplements, but what we know is that there's sort of quite there's a lot of variation in terms of who takes supplements and what the awareness is about taking vitamin D supplements during the winter months. So really the kind of fundamental purpose and aim of this pilot is to increase uptake of the NICE guidance. So we're not doing a clinical trial, we're not going to be trying to measure health outcomes from the pilot, but we're just going to be measuring, have we, through this pilot, have we increased uptake of the NICE guidance, which is daily vitamin D supplementation. And then very briefly on the next slide, we've decided to focus on residents aged 65 and over because that age group is obviously a risk group in itself for being vitamin D deficient, but also we know as a sort of across the whole of Newham's population, a large proportion of that age group have other risk factors, including being from a Black or Asian or other minority ethnic background with dark skin, so more at risk of vitamin D deficiency, particularly in the winter. And lots of our residents have had limited exposure to the sun, particularly during lockdown. So I'm not going to dwell on that, the rest of what's on that slide. In terms of what we're doing, we're going to be giving out the supplements and the accompanying information across a range of settings. And one of the things that we've learned recently through COVID is that we can really reach out quite widely into our communities through working with multiple different partners who interact with residents in different places. So whether that's faith settings or community centres, libraries, social care settings, primary care settings, what we're hoping to do is kind of really work across a broad range of settings to engage residents when they come in the places that residents go. And we'll be training the staff in these distribution sites about what we're doing and why, and how they can communicate simply but clearly with residents about why we're doing it. And then we'll be monitoring and evaluating the pilot, working with Queen Mary University. So we hope to get a really solid evaluation from the 6 months as well. So if we just go on to the next slide, and this is where, the one before. Thank you. So this is where I'm here really to find out whether any of you would be interested in supporting this pilot. And there are two main ways that you can support it. So on the right hand column in that table there, it's about promoting the offer. So just sort of joining up our communications, letting your patients know that this is available to them for 6 months. They can get vitamin D supplements for free if they're age 65 and over, and where they can get them. And we'll be providing all of that information and putting it on the website and things like that. On the left hand column is if you in your practice or any other sort of facilities that you run would like to actually act as a distribution site itself. So that would be, I'm not going to sort of run through that whole list of what that would involve, but it would basically involve storing the supplements and any sort of accompanying leaflets that we would give out to people, giving them out to residents, collecting some information about the residents at the time, and that's really important for us, knowing who have we reached, how many, but also what has been the equity impact of what we've done. So have we reached a representative group of residents who we'd want to reach? and then working with us and our coordination team to sort of restock if you run out and that kind of thing. We absolutely love as many of you as possible to be involved in one or both of those areas, and I've put my details on the last slide, so if you are interested, please do let me know by email. If we just go on to the next slide. Now, we've had some conversations already with various people from the CCG and primary care and pharmacy, and a few kind of key questions and concerns from the primary care perspective have been raised. And so I firstly want to sort of let you know that we're very aware that you might have some concerns, and we absolutely want to hear from your perspective about what do we need to make sure we make really, really clear to people in this work and avoid any sort of unintended negative consequences. So I think what we've heard so far and what we're taking into account is people should absolutely not come to their GP and request a test for deficiency. GPs don't prescribe these low dose supplements, and people shouldn't expect that they can come to you and have sort of free low dose supplements on an ongoing basis. So after this 6-month pilot is finished, if residents do want to carry on taking supplements, then they will need to buy them, and we will be looking at our evaluation to then assess, is this something that council would like to do in the long term? And I think those are really important. It's really important that we make that very clear. But again, I know we don't have a huge amount of time now, but if anybody has any comments about anything else that you'd really want us to bear in mind, then please put it in the chat or tell me now, or you can email afterwards. And then the final slide is just in terms of the next step. So we're going to start the distribution early November, and probably with a staggered start throughout November for our different sites. So we sort of start with a few, learn, and then kind of improve as we go throughout November. There's my email address there, and my colleague Ashley, who's working on this as well with me. And so please do get in touch if you'd like to be involved. And at the very bottom, a plug for our 50-step strategy, which is the health and wellbeing strategy across the borough. So I'll leave it there.
Thank you. This sounds fab. I think all practices will want to be getting involved. Just two quick things. I think Mavis has pointed out that with regards to the distribution sites, it may be worth considering if it can be done at a place of worship, so patients don't have to go. And I think that Helen has pointed out that the NHC team will be supporting with this project, so that when they're going around doing the housebound flu and COVID administration, they'll be distributing the vitamins at that time as well. So this is all fabulous. So I think if practices can sign up, whether it's to be a distribution centre or whether it's to provide the information, I think it's of real benefit to our practices. So thank you.
Thank you. Thanks for having me.
Okay, just I'm aware of the time, but I do want to hear, and I'm sure we all want to hear from Kavita. So can I just ask everybody to stay on an extra 5 minutes or so we can hear from Kavita, and straight over to you, Kavita.
Thanks, Arpana, and thank you both, Karen and Arpana, for giving me this slot today. So I am between you and your weekend, so I'm going to speak really, really slowly now to drag it out. I'm joking. I'm going to talk as fast as I can. So I've been asked to kind of come and explain a little bit about the training hubs, and especially around the governance and accountability around a procurement process that is happening at the moment. So I'm sorry, I know I hate structure charts, and I know my brain is a bit frazzled already at the moment. So I'll just take you through this. So we are the little blue box in that corner, at the bottom corner, and we report in, each training hub reports into a NEL collaborative, which formed about 2 years ago, which then kind of has accountability to a STP facing training hub board, which has direct accountability to HE primary care school, which then reports up nationally into the national HEE. Because we have different funding streams, we also have reporting and accountability into the SMG, the ICS SMG. I think this is all going to change, and this is a bit of an old slide actually. This is about from a year ago, so Jane's name is still on there, so we need to change that as well. So I hope that explains it a little bit more, but the key thing is that our direct lines of accountability are to HEE, and we do regular KPIs, regular reports, regular reviews. And yeah, but they kind of helped us and cut it down during the kind of pandemic to kind of reduce the kind of burden of reporting on us. Can we just go into the next slide? So this is our NEL ICS facing board membership. We have an HE rep, we've got the NEL Training Hub management leads, we've got Dr. Jyoti Sood, who are NEL ICS facing lead and chair, and then our clinical leads. And we've got a really great, talented group of NEL clinical leads, actually. So for BHR, I'll come to that in a minute, Wax. It's on the next steering group page, slide. So for BHR, we've got Jyoti, Dr. Jyoti Sood. For Waltham Forest, we've got Dr. Munir Ali Zubair. Sorry, I didn't put their names on, who's also an HEE AD. For Tower Hamlets, we've got Dr. Phil Bennett Richards. And for City and Hackney, we've got Dr. Nisha Patel, who we may be changing, but so we've got a really great group of clinical leads there, and we've got really great management leads as well. And Jane Lindo is the director of primary care that we link into there. So if we just go, so I'm really easy if anyone wants to unmute, ask questions, and we've got lots of Training Hub members here. So Mavis, Sabir, our vice chair, Tammy as well. Actually, you're all part of the Training Hub. So if anyone just wants to unmute and just kind of speak, that's absolutely fine as well. So Wax's question about practices. So this is our, so each training hub, each locality training hub then has its accountability. Of course, our accountability is always to our borough and our patients, but it has accountability in its membership of the multi-organisations. So this is the membership of our local steering group. So this has been an ongoing thing. So I think is how much, and I think, again, we're kind of trying to work this out. So there is some local flex around decision making. There's a little bit of local money funds that comes through for local decision making. But a lot of our funds is actually kind of already set out how we spent it by HEE, and also, so and just we kind of agree an amount that's going to be taken off. So and then around the local decision funding, we try to consult all of our partners. I always think it's a network, because people are like, my gosh, there's your network is just 60 people. It's hardly a board, which I agree with. So, but I think it's we try to be as inclusive as possible. Anybody that's interested, come join. We have tried to manage it, so we do it in a kind of do the decision making in an inclusive way. Mavis, I don't know, and Sabir, I don't know if you want to add anything right now. I'm putting you on the spot. Sorry, guys. Mavis, because you come to yeah. I just don't know if everyone wants to keep on hearing my voice. No, Sabir, anything? No, brilliant. Okay, fine. So as you can see, it's quite a wide-ranging steering group. So it's like ELFT, LBN, voluntary sector, and it varies the kind of engagement that we get according to how busy people are, obviously. But the main thing is that we've done lots of training and projects across sectors. We try to pool our resources. The thing that I really want to work on a little bit more now is workforce planning across kind of the organisations as well, which I think could get a little bit difficult. Claire, your question, operationally difficult to manage. It's tricky, isn't it? Because actually they're there because of the purpose and their goodwill, isn't it? So I think it's people's time, and it's not that they're there because they have to be there in a kind of paid role. So operationally, sometimes I think motivating, and making sure people have that kind of time to come to the meetings, and developing a strategy. Yeah. So what we've tried to do is, if we go on to the next slide, is I'll mention this in a second. The slide after, sorry, Maggie, and then I'll go back to that one, is what we've tried to do is we've tried to look at the ELFT strategy, workforce strategy. We've also looked at the BART workforce strategy. I loved the ELFT one, actually. It was this really lovely, simple page, and we've pulled it together. And this is our Newham priorities. I really do think I've written draft because it hasn't been signed off by our local steering group yet. So this is draft, but I think it's really important that the priorities are actually done by the people who are going to work on them. So that's why it is like, I know it's a pain, but like it goes out to all of our members before it's signed off. So the engagement has happened. That happened at our last development meeting about a month ago, 2 months ago. Sorry, somebody just came in. The next step is to kind of set up those priority groups. And then also, this is what I was going to say. We are also working on the TNW priorities, and there's also NEL priorities as well. There's obviously overlap, but I think it's important to have your own kind of local priorities that people feel ownership of. Of course, there's going to be overlap there. So can we just go back to the last slide, Maggie? So in view of kind of all the changes, National HEE team have said that to allow for recurrent funds into a sustainable kind of process, we have to go through a procurement process. So the procurement process means that there will be providers or NHS organisations putting in proposals to be the host for the NEL ICS training hub. The ITT, so the invitation to tender, was 16th of September. The deadline for submission is 18th of October, and then we'll get the, obviously, I can't really share more than that because it is a procurement process. We don't envisage as training hubs that we are going to have our the structures are going to change too much for us. Our accountability will remain the same towards HEE. So hopefully, and the host is actually just, it's a vehicle for finances. So I think it's 2:05. I just want to take any questions on that particular point, if anyone's got any questions, and then I'll just quickly show you our activities and how they map to the priorities. And hopefully Karen will and Arpana will have us back and we can go through our activities in a bit more detail in another meeting.
Okay, so can I go to Claire first?
Yeah, thanks, Kavita. That was a really good overview. I guess I'm just thinking about, because it was really helpful, the slide where you're saying there's North East London priorities, there's TNW priorities, there's Newham priorities. So I guess it's wondering about, because there's a lot, I mean, you send out loads of emails, there's a huge amount of work being done by the hubs, but it's just trying to think, is that being driven from local requests, or is that what Health Education England is saying, this is what you need to deliver, or this is what, is it the North East London that's driving that? Because it seems like there's a lot. If anything, it feels as there's a little bit too much, and I'm not sure how much the practices are sort of communicating with you and saying what they need, basically.
Yeah, it's a really good question, Claire, and it is too much. Believe me, I feel it's a bit too much. So I would say a lot of it is HE driven, but I say HE driven, but it makes sense for us on the ground as well. So it's not I don't feel it's like oh gosh, why are HE asking us to do this? It actually makes sense. So the kind of the fellowship programs and some other projects, which I'll tell you about in a second. The requests from the practices, I think, we do. We get lots and lots of emails about, could we have this piece of training, that piece of training? So that is definitely coming through a practice angle. We try to consolidate it a little bit and do it through TNAs, training needs analysis, and we're trying to set up the PCN workforce leads program to make it just a little bit structured. If ad hoc requests come through, we do have a kind of a business case template, because obviously we just have limited funds. We can't just, share them out here and there. So as to, whether we can allocate that piece of funding for a particular project. Is it NEL or Newham? We all work on the same kind of things. We all have the same kind of funding coming through. We're all working towards the same operating framework. Now, there's some local flex with some funding. So, for example, in Newham, we pushed the health equity leads angle a lot in Newham, which was then picked up in the other areas. But what we do is we do something and then we take it to our NEL collaborative and say, look, is this going to work for you guys? So the health equity was some flex. We pushed the kind of the setting up of the hubs ourselves, but then that's come through a national directive as well. So I would say it's really difficult to quantify it, Claire. I would say about at least 70 to 80% is from HEE directed, which is always a conversation that we have with HE anyway through our primary care school board. And I think there's a little bit that we have a bit of flex on. If we just go, oh, sorry, Wax has got his hand up as well.
I'm sorry, but I think we're missing the point of the discussion here. There's a big word that you mentioned in the presentation, all the great work that's happening, but you've mentioned the big word P. There's a procurement happening next week.
I was trying to...
Yeah, no, well, no, I think we need to be honest and transparent with the practices. There's a procurement happening next week, and there's going to be one training hub, which what Kavita's articulated will be supporting, we hope. But we don't know, as you know, because of procurement processes, what those business cases, or we haven't been engaged. I have to get to another meeting, but I think it's an important point that if we are carrying on discussing here or in other forums, I know the procurement's next week, but we discussed the risk to what's been great in Newham over the last few years around training. You know, it's pretty much primary care embedded. Practices look up to the training hub for support, fellowships, spin kind of situations, nursing training, admin training, the monthly meetings, etc. We could roll off a whole list. I'm not sure, and I'm not confident at this moment in time, because we haven't been involved in the process around procurement, and I think that's disgraceful from HEE, I'm confident that all of that great stuff that Kavita and the team are doing is not at risk now. And whether we're going to get our equitable share when we go to North East London, I'm going to leave you all to discuss that. And that's a bit of a negative point, I know, to leave it, but I do have to get to another meeting. But I think we need to challenge this back. This will happen, but we really need to be clear with whoever wins that procurement, and it will be one of our local federations in North East London, most likely. But you know, what are the risks to the great programs that we've done?
I think we just need to be really careful here. This is a procurement process, so that's why we just need to be careful with what we say here as well.
It could be anybody, Kavita. So it doesn't matter. It's out there, and it's training hubs, it's other organisations, it's BARTs, it's your ELF, it's etc. 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 We don't need to be so cute about it, but I'm more worried about the risk to my practices.
Yeah, so I would say that equity is very high on our agenda. It's something that we take to every collab and STP ICS facing board. It is something, obviously, with the workforce issues, you know, with BHR, Newham and Waltham Forest being, you know, disproportionately affected with our high rates of underdoctored areas, of really high rates of being underdoctored and under. So look, I would say there is a really strong push from HEE that we maintain our local systems. The host is just going to be a vehicle for finances. I do not think we should get too worried about this process. I cannot envisage the training hub stopping doing all the work that they're doing. And I cannot imagine that the host would want to stop any of that work. It would just not be it just doesn't make sense. And if that was to happen, then we have our accountability and governance structures. So we are accountable to HEE, we are accountable to the STP ICS facing board, and you know we would not be happy with that, obviously. But I just cannot, you know, I think it's something that they just had to do to make sure that the finances were in place. So, and I think it's very difficult to speculate at the moment. I think we'll come back once the procurement process is over.
Thanks, Kavita. I think the issue here is I think it's really important to maintain that transparency with the practices so that they're aware of what's going on. I appreciate it's still in procurement, but I think the key there is transparency. Can I just have a quick comment from Anil?
Hi, Kavita. Just protected learning time. I think we all as practices really want protected learning time. So is that within the gift of Training Hub? And also just regarding what influence directly as practices can we have on the training that Training Hub delivers? You mentioned that all the time that it's HE driven kind of agenda, they're deciding on the courses, what's offered, but actually at practice level, I'm speaking to a number of my colleagues on the ground, the training that you offer isn't really relevant to us we want some other stuff that really relevant to our receptionists, our healthcare professionals seeing patients, what really happens on the ground training, rather than the ad hoc kind of really wishy-washy stuff that does come out of Training Hub. And I know it's not you directly, but it's HEE. How do we as practices across TNW now influence what is delivered? Because you said 20% only comes locally. It's not enough. You want it 80% locally, 20% HEE.
Okay, so yeah, so lots of important points there. So this is not going to be a quick 5-minute thing, is it? So open up, the transparency is really important. So actually, we were one of the first areas to share the procurement information. Well, we try to do it at NL level as well at the same time. So we have shared it through our Training Hub members. We have, as all those stakeholders are there, and I'm accountable to my Training Hub members, and through NHC Federation and through the CD rep, which is annual, but I know that it's been a capacity issue. So that's the way we process our that's our governance and transparency around it. I'm not just accountable to practices, I'm accountable to across the whole system. So, and I think that's really important. Of course, I'm accountable to practices, but I want to make the point that I'm accountable to all the system. We're cross-organisational. So the way the mechanisms is through our Fed representation on our steering group and through our CD representation on our steering group as well. And then obviously, coming here, Karen's request to kind of further give that transparency. The reason I was saying kind of push it aside is because I don't want people to just focus on the procurement process. I want us to focus on the real governance, the real activities that we're doing at the moment. So that's why I was, not because I was like, don't talk about the procurement. I was like, I don't feel it's the most important issue at the moment. Right, Anil's question is really important. So Anil, the thing is, sometimes I just don't think there's I think it's a mixed bag. So I think there are a lot of things that we do that are kind of on the ground that is really needed. There's a lot of stuff that is aspirational as well. And there's a lot that doesn't fall in our remit. So Stat and Man has never been in our remit, but over the years, Training Hub has supported safeguarding training and funded it, supported infection control training, supported, there's so many programs, which I don't think people actually realize is actually part of the, the Training Hub work. So, for example, the kind of all that medical assistant pathlinks training was from a bid that the Training Hub did. All the kind of CPD, cervical smear training, 143 COVID vaccinators trained up, the fellowships, 5% increase in headcount in our GPs. I think it's completely relevant to general practice and primary care, but I completely get your point that it would be we can make it even tighter and improve it even more. And that's why we really need our CD's engagement. We need it through the TNAs. We need it through the kind of the induction checklist that I even just sent the other day to say, look, CDs, guys, is this relevant? Is this what we need to be working on? And it's through the TNAs. We have a whole CPD program, which has been, was done again through a TNA. That everything we base our needs on is coming from the practices. So where we can flex.
Positive. So I think in terms of TNA, TNAs that you're carrying out, I think that information can be collated. But I think what practices would want is things to be done more quickly and more. I know obviously all these things take time, but I think if you're carrying out a TNA, we want to know what the outcomes are. We want to, see that training being set up quite promptly, because I think we need all of that training as ASAP, not further along down the line. Dr. Sen, just a quick comment from you, then I think I'll have to close the meeting.
I just wanted to mention something. Look, I did a lot of regulatory inspection to Tower Hamlet, City Hackney, Walthamstow and Redbridge. All their mandatory training are done on PLT. And I'm just looking for that sort of concept is coming to the PLT. We need to do the things, what we are doing all unnecessary. Also, we need to equip the practices to base the regulator. So I will just emphasize here that next PLT, whatever we do, is all about what matters to practice more than all these other things. Because remember, we need to really provide those kind of service, not just 2 weeks before the visit.
Yeah, absolutely, Sabir. And we put in a business case for PLT about 6 years ago. and it wasn't approved. And now we have, through our BAME guiding group, campaigned for PLT. We have gone to Marie Gabrielle. I've had email conversations with William, and we are influencing the system as much as possible. Arpana, is it okay if I just show our activities quickly, the slide?
Yeah, just quickly.
Is that
Sorry,
okay?
I'm just conscious that
Thank
everybody's
you.
got clinics and things to get back to.
I know, but Anil's raised a really good point. So I need to kind of, so if we go through this, if you look through all these schemes, Anil, and work, all of the, so this is just our recruitment intention. So this is, yeah, PLT, Anil is funded through their feds and underspends. So, you know, this is not Training Hub remit.
I just think as an organisation, we need to be pushing PLT, because if it's happening across the patch, why is Newham?
Absolutely. And Tammy and I are on it. Yeah. We are on it. We have been emailing, and Mavis as part of the kind of main group. So I think we are on it is something, and I've taken it to the STP ICS facing board, discussed it with Jane Lindo. So, you know, we are on it, but the funding is not in my gift to give for PLT.
You want to get one sorted, I'm sure all my practices will too as well. So whatever we need to do together, LMC.
Yeah, absolutely.
Let's do it.
Absolutely. So yeah, so City and Hackney have PLT, and so do Tower Hamlets. And I have gone into very much detail of how their PLT is funded. So
to ring fence any monies from HE just for primary care, because I know you talk about working together across the system and acute trusts, etc., coming in, and with the proposal coming next week that you might be taken over, can we ring fence any money for primary?
We're not going to be taken over. This is why it's a training. The host literally just hosts the finances. That's all they do. So they are just a bank and an invoicing process. And with so this is why I want to get really clear.
Yeah, but can we ring
the training hubs are not going to? They're in the long-term plan. They are a mechanism of HE. Training hubs are not going anywhere. So, so I just want to reiterate that. And if you look through these programs of activities, all of them are for primary care and general practice. I would probably get more challenge from ELFT and BARTS and LBN, as in, what are you doing for us, to tell the truth? So if we just, you know, so the practice fellowship scheme, the coaching, which is part of the delivery, all the forums and all the training that happens through that. If you go on to the next slide as well, sorry, the the GP and academic and foundation program, that's all new nurses that are coming into general practice. The CPD program is our rolling, is all that kind of smears. I think that could have been tighter, Anna. I agree with you. I think that could have been a little bit tighter, but they had to literally roll that out within 3 months. The whole CPD for across all of NEL. So that was dementia training, all of the training, the flu training, and the COVID vaccination training has just been like, you know, like getting 143 vaccinators trained up within 4 months. It's just been like, my gosh, right? And then, okay, so
well done, Kabir. You've done a brilliant job.
No, what I'm trying to say is that I think sometimes people don't realise. You know, sometimes, and also another responsibility that's been given to us now is the training practice approval. So that's also going to be, we're starting that as well. Sabir's helping us on that. So now we have to do multi-professional learning environment assurances and also training practice approvals as well, and the apprenticeships and all the wellbeing work as well. So it's an incredible amount of work, and a lot of it is based in general practice. And I think it's a perception. It's a perception that we need to challenge. So, and as I said, I am also accountable to all the organisations in Newham as well. So okay. It's not happening, is it?
No, Claire. We will definitely have you come back as well, because I think there's lots to hear from you, and it's really good to see all of the work that's being done. Can I have the AGM slide up again, please? So thank you all for staying back as well. I appreciate that, you know, we've all got clinics to get back to. Our next meeting is on the 14th of October, but in just under a fortnight, we've got our annual general meeting. Everyone's most welcome. We look forward to seeing you. It's going to be a face-to-face event. So, you know, most of us haven't seen each other for a really long time. So it's going to be a great evening. Please do join us. We look forward to seeing you. And thank you for joining the meeting today. Okay, if anybody wants to stay on, please do feel free to stay on. If not, have a lovely weekend. Okay,
Bye,
thanks.
everyone. Bye. 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 Bye.
Hi, Arpana. Sorry, I've got an appointment that I'm on my way to, so I had to jump onto the phone.
No problem. I'm still having trouble with timekeeping.
Well, there was a tremendous amount in that, so hopefully colleagues got a lot of information. So it was just packed. But anyway, thank you so much for sharing.
That's okay. I didn't realise that Nadeem was off but still working. Basically, he's taken annual leave but still been doing all of this work. So when I spoke to him yesterday, and he mentioned it, I said no, it's fine. I'll somehow manage. So, but baby's fallen asleep, or she's
brilliant. Really well.
she's falling asleep because it had gone quiet, but she's awake. But no, thank you.
Okay, I will catch you later. Thanks so much, everyone, for your contributions.
Okay. Sorry for going over. Sorry for going over. It's all my fault.
I think the
fault too, Hannah. Sorry.
No, it's not a problem. It's, there's so much to cover, and diabetes, that all of us deal with diabetes, and I think the things that you covered, like the low calorie diet program. So I think the reason why I was asking